It's my distinct pleasure to introduce this morning's speaker, Dr. Marsha D. She was Professor of Pediatrics and Behavioral Medicine in the Department of Pediatrics and Human Development here at Michigan State University, and she was the Dean of the College of Human Medicine from September 2006 to August 2015. She's currently Professor of Pediatrics and Psychiatry at Virginia Commonwealth University in Richmond, Virginia. She's also Vice President for Health Sciences and the Chief Executive Officer of Virginia Commonwealth University Health System. Dr. Rappley obtained her Bachelor in the Science of Nursing degree from Ann Arbor, where she graduated summa cum laude. She obtained her medical degree here at Michigan State University College of Human Medicine, and then returned to the University of Michigan, where she completed her residency in pediatrics and a fellowship in pediatric neurology. On completion of her fellowship training, she joined the faculty at Michigan State University and was director of the Division of Developmental and Behavioral Pediatrics, General Pediatrics, and Ambulatory Clinics, as well as the Collaborative Development Clinic. Subsequently, she became the interim chair of the Department of Pediatrics and Human Development, Associate Dean for Academic Affairs, and Acting Dean before she assumed the office of the Dean in 2006. At the peak of her research career, Dr. Rappley was a funded investigator with several grant awards, including NIH grants. She has published extensively in peer-reviewed journals and authored several book chapters. Her main research focus has been on attention deficit hyperactivity disorder, an area in which she has distinguished herself. Despite all her academic achievements and leadership responsibilities, Dr. Rappley still finds time for service and community engagement. She has won several honors and awards, and although time will not permit me to list them all, I would like to enumerate a few of them. She won the Women of Achievement and Courage Award in Healthcare, Education and Research, presented to her by the Michigan Women's Foundation. She was named one of the 50 most influential women in West Michigan by the Grand Rapids Business Journal. She won the Distinguished Service Award by the Food and Drug Administration, U.S. Department of Health and Human Services, recognition of Distinguished Service by the American Academy of Pediatrics, Section on Developmental and Behavioral Pediatrics, Alpha Omega Alpha National Honor Society of Medicine, and the Ray E. Helfer Resident Teaching Award, presented by the House staff at Michigan State University and Sparrow Hospital Pediatric Residency Program. So I would like us to make some time to listen to her beautiful presentation. Otherwise, I could go on and on and on. She has no conflicts of interest to report in the preparation of this talk. Please welcome Dr. Rappley as she presents shifts in the burden of care and how that affects the health of children and families.
Thank you. Thank you very much. I have to say that it was Michigan State University that really gave me the opportunity to have any of those kinds of opportunities or awards that were just recited. It's when as you get towards the end of your career, you think about how did you arrive at the place that you're in, and it was really the support of the amazing faculty of the College of Human Medicine from the time I was a student that supported me in all of this work. So my gratitude is enormous in that way to all of you. And then, when I look at the students who are coming into the work that we do right now, we are passing the baton to you, and it's very exciting to see the kind of idealism and enthusiasm that you bring to the career before you, and we will help you to find as rewarding a career as all of us have found in work, especially in pediatrics. So I'm going to try to talk to you a little bit about what I think, sort of the perspective that I have as CEO of a very large health system and also being responsible for 5 different health colleges. What are the ways that I might speak to you, a unique contribution that I might make to you rather than thinking about a disease or a condition. So I hope that this is helpful to give you a perspective about what I see happening to both our health systems and the children and families that we serve and how those intersect. A little bit just about us at VCU. We are an operation of a health system operation of about $3 billion per year, so a very, very large system, and we extend across the entire Commonwealth of Virginia. We have 3 business components to what we do in the health system. One is hospitals and clinics. We have about 7 hospitals in that collection, and a very large clinical ambulatory enterprise. And then we have Virginia Premier, which is a managed care program. It's a health plan. It's similar to PHB, but it's Medicaid and Medicare based. And we have about 200,000 covered lives in that. And that's a very large part of what we do, and has helped us to learn about value-based care, and I'll talk about that in a little bit. And then we have a very large physician practice, which is about 800 doctors employed by VCU Health, and all of those physicians teach in our medical school as well. And then we have our health colleges, so dentistry, nursing, pharmacy, allied health, and I'm forgetting one. Let's see, did I say pharmacy, nursing, medicine, dentistry, allied health, yep. And about 4,000 students at any one time are on our campus from all of these different schools. So all the way from undergrad and allied health to our professional students in medicine and pharmacy and advanced nursing. And then we have about 700 residents with us as well. So, and then what you see on the right of your screen are all the other colleges that are part of Virginia Commonwealth University. It's an urban-based university, so that's a really exciting thing to be part of. And I went down the list here again. Every single one of these other colleges works with our health system in some way. Either has students training in our hospitals and clinics, coming out of business and engineering, or has faculty from art. So the art faculty in sculpture work with our neurosurgeons and model brains and skulls and things that they will be doing. So lots of really interesting creative things connecting to the whole of the university. So that's what makes my job fun. And then what makes my job hard is looking at these burdens of care that we're seeing increasing across the nation. So when I talk about burden of care, I'm going to talk about shift of course and responsibility for payment for services. So we all understand that's coming. It's going to cost every one of us individually more money to receive our health care than it has ever cost us in the past. And it's going to cost our employers, if we are in employed health care, more than it's ever cost in the past. And that's going to have some impact then on what happens within our care delivery models. But we're also shifting responsibility for management of the care in some ways to the patient that may not be always apparent to us. And that's a burden, an extra burden that they carry. So I'm going to talk a little bit about that. And these two things together demand that our health systems respond in a different way to the needs of our patients. The burden of treatment theory, this is the article that I think really explains it the best. Dr. Victor Montori from Mayo Clinic is a big part of developing this as well. I've spoken with him. I think it's quite, I think as a pediatrician, you'll recognize many of these sort of things that they're exploring now in a very research-oriented way. They're looking at the relationship between the patients who are sick, their families and social networks, and also the healthcare services embedded within those networks. And what are we delegating to people who are actually sick, and what do we delegate to those who take care of them at home and in their community? On the one hand, it's recognizes that the patients are capable and very important in decision making and are the best people to advocate for their own health. But on the other hand, it places a lot of demands on people who are quite sick, and they may experience some burden of care. People can get overwhelmed in this. We'll talk about this a little later, but you often see this in your clinics. People just don't know what to do. They don't know how to They try to go register for Medicaid and then come back and tell you that they waited all day and never got their appointment. You know, they try to get their records transferred and they get no response from the group they're trying to get the information from. It's very frustrating for people, and often these are the people who have the most demands, whether it's a mother of a sick child or a sick person themselves. And it just provides us another way to look at issues of compliance and cooperation. You know, there's a lot about the behavior of the patient, and there's sometimes it goes to the extreme of blaming the patient for not taking better care of themselves. But this provides us a frame to examine how difficult it is sometimes for our patients to fill their scripts, to understand what's happening to them, and to really be part of their care. But let's start then the discussion about the shift in these burdens by looking at the landscape that affects us. We'll start with our health system landscape, and then we'll look at it from the point of view of the patient. But we all are experiencing a decrease in our revenues. It really doesn't matter which bill passes where or what is in that bill. Now, I'm not saying it doesn't matter, so let me back up. Some bills could be a lot worse for us than others, but they all are showing a decline in the payments that will be provided for the services we now do. So looking at reimbursement, whether it's coming from Medicaid, Medicare, or the private insurance companies, they are all looking to bring down the amount of money they pay us to do the work that we do. And that's across the board, whether that's inpatient, hospitalized, clinic, outreach, public health nursing types of roles. It's all being ratcheted back. We have the possibility of decreased revenue as we look at shifts among our providers and our insurers, consolidation there. So a health system can suddenly find itself without a large portion of the market that it has always served because 2 or 3 mergers happened in other health systems. And so that is something that the health systems always have to be alert for and monitoring, positioning themselves to be in the right consolidation of health system in order to not be left out. As we look at our insurers consolidating, a lot of people think we might end up nationally with 3 or 4, which means they will have all the leverage. And for example, we have people from one of the larger insurance companies pretty gleefully telling us that our next contracts are going to be a lot lower than enjoying right now. So there's this constant leverage of that power that comes with the consolidation. And then even things like our GME support, which has come primarily from the federal government and through CMS, Medicaid, and Medicare. For example, the question of indirect support. It's really difficult for us to explain to people what is indirect support and how do we use that money. So it becomes an easy target. Oh, well, it's not directly supporting the training of residents, so we can just take that back. It's a huge amount of money in the health system, and the way that I've learned to talk about this in its most simple aspect is most hospitals are already putting in more money to GME than they receive in total from the government. Now at VCU we put in $70 million a year over and above what the government provides us for GME support. So there's no extra money. We're putting in $70 million to that. So when they talk about indirect as extra money, it's really an important fight for us in the halls of Congress, but it's very difficult for the average person to understand. And then in our cost column, of course, in pediatrics, we live, and hopefully we don't die by them, but we live in the midst of unfunded mandates for as long as I have ever been involved in pediatrics. So here's what you have to do to get paid, but we're not actually going to pay you to do all that stuff. And you got to make sure you have all those types of people providing care and specific aspects of care in order to get a payment that fairly pays for the patient to come through the door. Now, I'm complaining, and I have to be careful. I'll complain about this to other business owners who are feeling crunches in the work that they do and have always had to deal with that, and feel that frankly we're quite fortunate that we've never had to deal with these kinds of things until now in healthcare. But nonetheless, We are always struggling with expectations that people have that aren't linked then to payment for those services. They also have to be thinking about the investment that we make into value-based care. So when we had the healthcare reform that came under Obama, it was very clear that we were moving strongly to value-based payments. And so we had to think about, do we have the right infrastructure to support patients after they leave a clinic, after they leave a hospital? But that's investing in things we haven't always invested in. Now we're not sure where this is going to go. It's probably not going to be all value-based. It'll still be some volume-based and some traditional models. But we've got to strike that balance. And I'll talk a little bit more about, even if we don't get paid for it, people are going to be expecting more value for what they receive from us than they currently have received, what they receive now and what they've received in the past. And that typically means things that we don't control. And so that makes it increases the complexity of that. And then there's the cross subsidies that have always flowed from the health systems into medical education and medical research. So when you look at this across the nation, medical schools across the nation, about 51% of their revenue comes from the health system in which they operate. Whether they own it, a partner, or however, whatever the configuration, that's a very strong funds flow. And over the last 10 years or so, our health systems have seen very strong margins compared to what the rest of the country experienced. And even through 2008, when most operations, most businesses were experiencing serious declines in their revenue stream, our health systems were not. So we had a margin that was much higher than we currently have and than we will have in the future. So that calls on us to examine how we subsidize research and education in a way that can advance mission for the medical school, for science, and also for the health system. But those are difficult conversations when there's always been a lot of money crossing the transom, as folks in Virginia say. So the implications then for our health systems on all of these things are that we are really going to have to differentiate ourselves on value. So of course we're all driven to look at the outcomes, but our patients can now look at the outcomes as well. We've got to think about patient experience way beyond the nice facility and are people friendly to the patient when they walk in. That's a floor, okay? That's a minimum. Places that are not doing that are not going to get patients in the future. But we also have to show them that we can help them manage their disease and their condition. So that's going to take work that in pediatrics, actually, we might be leading the pack because we're very familiar with helping families work with the conditions of their children. And a lot of our adult colleagues, adult specialty colleagues, aren't really in that frame of mind. But that's where we all need to be. And we also can't forget, as a health system now, that we have to look at the experience of our providers. So really, the situation that we're in now, we were talking about this last night, where people spend a whole day in clinic. They go home maybe 6:30, 7. They have some time with their family. They go back on their charts at about 10 o'clock at night to finish their medical records or not. And I was one of those or not things. Like, I would go back on, but my charts were never complete. I was a real wrongdoer in that regard. I kept getting on the bad list. So that was a struggle for me always to keep up with my records. And that was a hindrance to my patients because the next person coming in didn't know what had just happened if I had completed that. We have to think about that environment for our providers. We have to think about the demand to do more, to work harder and more efficiently, and yet create a morale and a esprit de corps that will help sustain people in the work that they do. Because if our physicians and our nurses and our staff are burning out early in their careers, there's going to be nobody to keep up this important work. Our health systems also have to be looking at increasing our efficiencies and effectiveness. So that's a term I had to learn about. it actually means something. So it's one of those phrases that means you have to streamline the work that you do. You have to do it at a lower cost, and you have to generate new sources of revenue to support that. So most health systems are going through this in a very systematic way. Many have already done this. At VCU, we're looking at reducing our costs and generating more revenue of at least 10 to 15%. And that's 300 to 350 to $400 million that we have to look at pulling out of the system or generating new dollars to build up new system. Because if we don't do that, we're not going to have the margin to support education and research. So it's not even about just having the highest margin we can get to brag about it and get a better bond rating. It's if we don't have the efficiencies that allow us to keep a margin, we don't have money to shift to support education and research. And generating new revenue, sometimes it's a simple thing like looking at how you're doing your revenue cycle, all this, hammering on the docs to code properly, or hiring other people to do the coding because it's just so difficult to do. That's all about trying to capture fairly the payment that the health system needs for the work that's being done. The other aspect of that is much of what we do judged publicly, like by CMS and posted on the various websites, has to do with our case mix index. So if we're coding things as very simple or oriented towards only one diagnosis when actually the patient has 3 or 4, our case mix index shows up as very simple when in fact our work is very complicated. And we could be generating more revenue. I say that's the simple side because we have the ability to fix that. But new sources of revenue are something that hospitals are considering too. It's very interesting and raises a lot of ethical issues. But some have endowments that allow them to become, in a sense, venture capitalists and actually invest in new products and new kinds of entrepreneurial activity to generate revenue that goes back to help support them, education and research. Our universities, of course, are trying to do this as well. So it's a dicey kind of thing, and it requires that you have some money up front to invest, as most things do. But I think you'll be seeing more of that too. If we look at the landscape then at the same time for children and families, what we see is that coverage for them is likely to be decreasing over the next 5 years at least. Employee-provided insurance is either becoming less available or it covers less than it previously did because it's so expensive for the employers to carry. Medicaid is changing their threshold, so all the new bills coming forward, we'll talk a little bit about the one that probably will be voted on today, is going to look at changing the thresholds for eligibility. It may or may not be income of the family. It may be that it's stratified in different ways. One of the proposals is to do this by age, so that within one family, the children who are under 6 would have a different kind of coverage and a different level of coverage than the kids who are 6 to 12, and the kids who are 12 to 18 would have yet another coverage. So a family would be dealing with not only a difference in their own coverage as adults in the family, but each child could possibly have a different kind of co-payment, deductible, and healthcare coverage. The whole area of pre-existing conditions, of course, we are caught in that in a very big way, pediatrics. And I think that when we saw this possibility that that would no longer be people's access to insurance, there was this excitement among our patients and among all of us as well. And that's now going backwards on that one. So there's a very strong sentiment among many people that the well should not be helping to pay for the care of the sick. And so we're likely to see that the pre-existing condition becomes a much more expensive proposition for a patient and family. And we're also likely to see tighter control of utilization. And I don't know if you're experiencing that, but denials of services. We've always had for a long time, we've had the utilization of our meds and our formularies examined very closely, but this is increasingly happening in many other aspects of what we do. The families directly will be carrying higher premiums, so they will be paying more for their insurance policy, whether they obtain that themselves or whether it comes through Medicaid. Medicare in particular is going to be strongly hit by that, which means our families will be affected, and higher deductibles and higher copays. So last night, one of our colleagues talked about a patient with a yearly deductible of $13,000. So that's a pretty large chunk of money for a family to spend before their insurance kicks in. So the bill that is currently under consideration, and I put here that's very fluid, is very, very fluid. It changes hour to hour. So in some ways you could say, why bother even reading about it, because it's going to be different by the end of the day. But nonetheless, we do need to keep on top of what's being talked about and what is being voted upon. In the current bill that's before the House, states could opt out of key aspects of consumer protections. We used to live with 10 essential health benefits, so all the insurers had to provide a list of 10 things for every patient, thought to be fundamental and basic to healthcare coverage. States could decide not to require that. States could have a decision to charge more for those with pre-existing conditions, creating the high-risk pools that we need to deal with. And states could also increase the ratio of the difference in payments. So the proposal is that those who are older will pay more for health care insurance than those who are younger because they will be utilizing more health care insurance. But this will be a burden on the family. This may not be seen as a burden for a particular child, but if the members of the household include people, and people are having families later in life, and there are lots of multi-generation families that we work with. So this could have an impact on our families as well. And the last paragraph just gives an example. A state could waive benefits around maternity and newborn care. That will not have to be required. So you can have a family could be paid a lot of money for an insurance company that won't cover maternity care or newborn care. Doesn't have to cover pediatric oral and vision. I mean, some of us remember when nothing ever covered those things. But again, the chance of having them covered is something that we don't want to now lose. And states could charge higher premiums. So, the state of Michigan has been, I know we can argue about this, but in many ways they've been very generous with people and setting Medicaid eligibility thresholds and paying coverage for autism, for example. But all of that is subject to who's in office every 2 to 4 years. So there'll be lots of fluctuation in those things as well. Fundamentally, what's on the table now with the House, it alters Medicaid as we know it. And there are over 30 million children in the country covered by Medicaid. Last night I checked with my colleagues. It's 1 in 2 children in Michigan. So that's huge, if you think about it. In Virginia, it's 1 in 4, but it's because our eligibility is set lower. So you have to be a fraction of poverty instead of poverty line plus in Virginia to have Medicaid. There could be a cap of federal spending per individual, which would greatly affect chronically ill children. And again, it may be stratified within families. The Children's Hospital Association estimates that this would cut 80 to 100 billion out of Medicaid funding for children over time. So the notion that Medicaid is the safety net will not be true for most children moving forward should these bills pass. The reference on the Children's Hospital Association, I tried to put it in, my computer would crash every time I put it in. So you just do childrenshospitals.org and you can access their report on this. Yesterday, there was an amendment added to the bill that allowed many people to support it who previously did not. $8 billion is proposed to be put into a bucket to allow some compensation for the out-of-pocket expenses for those with existing conditions. But again, those funds will only be available to states that charge for those things. So it's kind of it's not much of a gain for families. And I've heard from my government relations people that maybe a vote that get this afternoon, depends on whether or not the votes appear to be available to pass it. It then goes to the Senate, so most people feel that it won't pass in the Senate, but it still could pass in the Senate. And I don't think we should become complacent and have to maintain the advocacy in DC and in our local districts around this. The implications for children and families is that healthcare is going to require more of the household income. So they're going to pay for fewer other things, or they're going to use fewer health services. They will acquire more debt, or they'll go without healthcare entirely. All of that is not good for us and what we do in every way you can imagine. The Federal Reserve reported on households in 2015. This report was issued in 2016. So they asked in their large survey the question, have you gone without medical treatment in the preceding 12 months because you couldn't pay for it? And for family incomes less than $40,000, 39% of people have done that. 39% of households have done that. 40 to 100,000, it's 23%. And even for those making more than 100,000, it was 10%. So it's thought that 46% report a major out-of-pocket expense from the prior year. Not thought, this is what they're reporting. They had to pay big time out-of-pocket in the prior year, and they were still paying for it at the time of the survey. There's this famous fact going around that people are citing on the radio in various places that 47% of Americans can't pay for an unexpected $400 expense related to health. So, think of how much a broken ankle costs. A lot more than $400. You go to the ED or the urgent care center. Pneumonia that requires a visit can cost this much easily. So there was a fact check. So you know how there's all this fact checking that goes on. And so this guy in something called the pundit check established that this was indeed true based on the Federal Reserve report. So it's thought to be fairly accurate that that as Americans, almost half the households are not really prepared to deal with an unexpected medical expense. So how are patients and parents going to manage this as they have to spend more for their care? They're going to be more selective about who provides that care, and they're going to be seeking higher value and lower cost. And they have to do that. And you all will have to do that too. So that when you are looking at who you will see and when you will have that dermatologic appointment or whatever has concerned you, you're going to be looking at who will provide that for you at the greatest value. And they're going to judge their experience with us, again, as I said earlier, beyond the physical amenities that we provide. They're going to be looking for much more accessibility than we have provided as physicians. And that's where using our other professions trained to do advanced practice can be very helpful in meeting the demands and the needs of our patients. And I believe that strongly in the future for our health system at VCU to make use of our advanced practice nurses and pharmacists and physical therapists to help us meet the backlog of need that our patients have. Telemed is going to be something that people expect to have on their phone, not on their computer. So just like people can manage their bank accounts and text, an order from Amazon, they're going to want to have an appointment with a physician or a nurse practitioner on their phone. And many places already do this. So those places who are doing this and doing it with an easy app that makes it very user-friendly are going to get the patients. And we have to help our patients manage their condition. So we have to watch how much of this burden of care we're shifting to them. I'll give you some examples in a little bit. But, you know, the medical home concept is all about that. It's about how do we help our patients manage through this condition that they have. And yet, many people have thought that that model has not been successful. It's been successful in outcomes, but it's not generated the kind of value-based payments that would create a nice margin for that activity. But I think that concept is where we all are going to have to be over the next few years, whether we get paid for it or not. Because if we're not providing that kind of assist to patients, they're going to go to those places that do. We have to be as prepared as we possibly can be for the decrease in reimbursements. So we have to be more efficient and effective in the care that we deliver. This is a change in culture for many of us. So it really used to be a lot about, if you deliver very good care, people will recognize that and they will want to come to you, they will want you to be their doctor. But that's not going to be enough anymore. The system in which you work is going to have to be as good as the individual care that you provide. And we have to rethink what it means to be patient-centered, especially around accessibility and the hours that we cover, and again, the way we use telemedicine applications. What this might mean for children and families is that they don't receive the care they need. Other family members don't receive the care they need. Families face worsening financial hardship. Most of us have been witness and have worked with families over the years to deteriorate financially. People lose their jobs because they can't keep up with the need for care of the sick child or children in the family. So while I think we have made strides towards improving those conditions, we are now going to be challenged to do that as there are more threats on that. We also have to think about as systems, and we drive this productivity, so everybody's giving you your RVUs and asking you how efficient you are in your work and how do your patients rate you, what's their satisfaction with the work that you provided. You've got to be careful that we're not shifting, again, the burden of managing this work to the patient. And I'm going to give you two examples. So this first one is more operational. So this kind of lies somewhere in your health system. You may or may not know where the office is that runs revenue cycle, but it's critically important. And this is a scenario we're playing out right now. Because we're a safety net hospital, we're commissioned by the Commonwealth of the university to provide access for all. So we really are going to be in a bad spot if we turn patients away. But we're also going to be in a bad spot if patients can't pay for the services that they get from us. So we're looking at revenue cycle, and how, that's another phrase I had to learn. You know, that is all about how do you capture the payments that are fairly due to you from the insurance companies and from the government. And one of the things we could look at, we need to improve, is our point of care collection of the copay. So when a person comes to get their care, are we asking them to make their copay at that moment? And some places we weren't doing that, and some places we were. Some places we were doing it very well and had a very high collection rate, but it was related to the type of care. So it was more discretionary type of care. And then other places we could say, see, we weren't doing a good job because the receptionist was interacting with the patient in a kind of, well, you know you had a copay. How are you going to pay this copay? Like that puts the patient on the defensive, and there are better ways to have a conversation with patients about the copay at that moment that you're providing the care. But if we turn patients away and we acquire bad debt as a system, then we have loss of revenue and we increase our infrastructure costs. So that's not a good thing. If we're turning patients away, fewer patients seek care, so our volumes go down. That's okay. And then they start seeking care episodically, and they're sicker, and they show up in the ED in the urgent care. And because we're safety net, we will be taking care of them. Nobody else will. And they're more expensive to take care of. And if we had treated them in the clinic when we turn them away, we wouldn't have them show up immediately. And we've got to find that right spot. That is a decision that we will make as an institution. That isn't a decision that the receptionist makes. It isn't a decision that the revenue cycle VP makes. It's a decision that, as an institution, we have to make. Where do our values and our mission collide with what we demand from patients, and how will we make that? How will we find the sweet spot, the best spot for all of us in that? Because otherwise, we're going to have loss of revenue on this side and loss on this side, and that's not a good cycle to be in. When we think about the burdens of care I've been talking about, these are two examples. So I took this from real case scenarios, either in patient experiences that I know about or come to know through my system. A patient has a new diagnosis of a disabling degenerative disease, but cannot have the appointment for treatment until the patient has collected many pieces of information from multiple sources. We're all familiar with that, right? I used to have this policy in my clinic. You can't have the appointment until you have collected all this information that we need to make the diagnosis and act on treatment. None of these places cooperate. So these are x-rays, blood lab results, multiple visits to different kinds of specialists, cardiology, nephrology, the whole works. So they don't work with one another to share information. And nobody returns calls. Nobody returns calls, nobody returns emails. The patient gets very discouraged and just says, okay, I'm not going to do it now. I need to take a break. I have worked too hard to try to get the information myself and take it to the clinic to get this appointment. They don't say, I'll never get care. They just say, I got to stop, come back to it when I have more strength. But symptoms worsen, and then this person requires care under urgent and emergent conditions and ends up more disabled and costing more money to the system. In the second column, then we look at, we know that this is something we know about from our data that's done across health systems around the country, that when a patient has surgery, when they're discharged, the likelihood of their readmission goes way down if in fact they have a follow-up visit within 7 days. And that could be to the surgeon or to the primary care doc or to the specialist. It doesn't matter who. As long as somebody interacts with them about how are they doing, takes a look at that wound, 7 days out, within 7 days out, the readmission rate and infection rate goes way down. If the patient's discharged, it takes a few days to call to get an appointment. It's told to come in 3 to 4 weeks. And, you know, that's not 7 days. And it just happens that they get an infection and they're readmitted. Bad for the patient. The patient has an infection that could have been prevented and could cause more morbidity. And bad for the health system because they've lost this reimbursement that comes to a judgment based on readmission and infection rate. So right now, from CMS, so from Medicaid and Medicare, and from the insurance companies, your health system, my health system, gets constant reports about how we're doing on readmission and infection rates, and our patients can read all this online. It's published publicly, and payments are adjusted accordingly, so that if we do well and we prevent the readmission, we get a bit of a boost in a payment. If we prevent the reinfection, we get a boost. And of course, our patient is better off because they're not having another visit and they're not reinfected. So this is the systems problem. This is like we know the fact, but we're not organized to get that patient an appointment, and we put that burden onto the patient. And that's the kind of thing we have to become increasingly aware of. And when I say help the patient manage their condition, it's around these kinds of things. A better outcome in the column on the right is also something I know about, where the patient connected with the specialty nurse associated with her diagnosis. And once that phone call was established, everything was easy after that. And the nurse was very reassuring to the patient and said, we'll have an appointment with the doctor for you, new diagnosis kind of thing, within 10 days. And whether or not we have all the information, we'll start a treatment plan and we'll take an evaluation of what still needs to come. Now, what I know on the systems side is that doctor can't charge the full, the full cost of a new patient exam when that patient comes in. But that doctor now has a patient who is a long-term patient and committed to care with that doctor because of the way that patient was handled. So while we may have been trained that we don't do certain things, that we have to do things a certain way to capture the most payment, we also need to look at how can our systems help make that happen in a way that doesn't increase the burden of care to our patients. So the next 2 years are going to be critical for many health systems, and some will do well and some will not do well. And I believe that it's going to hinge on our ability to differentiate on value and the fact that our patients are truly better off. So not that we're meeting some list of outcomes generated by some committee somewhere, that our patients are actually better and feel that they're better and know that they're better and want to come back to us because we help them to be better. That includes provider satisfaction as well. If our doctors are disgruntled and our nurses are unhappy about the way they're treated and the situation in which they work, it affects education, of course. So our students see this, our residents see it. But our patients see it. And our patients are not happy in this environment. So we have to pay conscious attention to how we take care of one another in our learning and care environment. And we have to decrease the cost. That's where the whole efficiencies and effectiveness comes in. And how we frame this for the people who have to do the hard work of that is very important. It can't be you're bad, you're so inefficient that you're costing us an extra $10 million a year. It has to be that, is there a better way that will make your life better and the patient's life better? Because the answer to that is yes. Absolutely confident that the efficiencies that we obtain are only going to be sustainable if the answer to that is yes. And because we have to reduce this cost. While it hasn't happened that I know of yet, I've seen denials come through. Deny the CT because we don't agree that it be done, but approve this X-ray. Okay. But there could come a time where, say, we need to have something removed, say another dermatologic condition, a Mohs surgery, for example. A denial may come through that says from my insurance company, we authorize this, but not at health system X because their cost point is too high. We authorize this if you go to health system Y. So our cost point is going to be very careful. It already is tracked very minutely, but there are going to be actions based on that. So this is something that all of us have to be aware of and helping to solve. But again, if we lower this cost point, we're lowering the cost of medical care, and that's an important thing for us to do. We're all experiencing these increase in demands. I don't think that we'll ever move away from the demand for higher value. Now that patients understand that it can be better than it was in the past, they're not going to be satisfied with anything. Whether we get a value-based payment for it or not, we're not going to be having the patients to take care of if they don't feel they're getting the most value from us. And while reducing the cost of care across the nation has always been a moral obligation, it never seemed like it was any obligation of mine in particular, because I'm in this system and I can't, how could I influence any of that? But it actually is an obligation for all of us to think about as integral to the best care. Because if we deliver care in a way that's more affordable to the patient, we've enhanced their ability to take care of themselves. The other bad news, of course, so sorry that this is kind of a cycle of depressing information, but I'm going to end on a higher note. But this same thing is happening in higher ed. So people are saying, you know, show me why paying this amount of tuition helps me to have a better position in life and a better income for my family over my lifetime. Show me how research that the government spends so much money on is actually helping me. And I'm telling you, I had explained to vice presidents at the university why we needed to spend an extra $300,000 on zebrafish. Okay? So, zebrafish, like, what is that about? What, do we have a zoo or something, you know, that would keep the zebrafish? And it turns out that zebrafish are one of the most important models for inflammatory conditions of any nature and for the immunologic treatment of cancer and other diseases. So we've got some millions of dollars wrapped up in research with these fish at VCU, and we had to do some improvements on their fish tank. I mean, it's kind of that basic. But everybody's saying, what's that got to do with my health, right? What's that got to do? Even people who have PhDs are saying, why should we spend money on zebrafish when we need to spend money on student affairs and things like that? So explaining how the research is related to our health and making those connections for people is very important. So all of us are going to be held more accountable for what we do in the value and cost proposition. I used to see all of this with a lot of cynicism and almost disdain, like, I don't do that hard stuff. I take care of patients. Somebody else is in that dark world of administration. They have to deal with all of that, and they don't do a very good job. That was always kind of my point of view. But really now, I begin to see it's not as simple as you have to have a margin to have a mission. That is crass. It's true, but it means that you have to use your margin for the greater good. And if we're going to use that margin to support education and research, and if our patients are actually going to have better lives because of what we do, and we're going to lower the incidence of infant mortality and maternal fetal outcomes and cancer and stroke to be comparable to other parts of the world, we are going to have to be more effective than what we do. And we're going to have to lower our cost point. So I now believe that all of this is within our ability in terms of how we organize our systems, but it takes a clear intent and a clear focus. And I guess I would say to all of you who feel that you can't control most of this, you have more control than you think. And you could look at what are the things happening in your own environment that could make it easier for your patient, and that could help you capture some of that, those payments that really you deserve because of the work that you do, and will enable you to do more of that work. So I'm going to end on that. I'd be happy to take a question.
Dr. English.
Thanks for your time. So one of the future advantages of value-based care might help support general nutrition, developmental behavior, other important spaces like health children, but live in a model where first have what they do out of the academic medical. Not valued by society. So, one day, you think you might get that value.
I do, but I think that only can happen within health systems that view themselves as a whole. So if we're pitting departments against one another, if we're pitting service lines against one another, and that is a kind of situation that individuals don't usually control. You can feed it in terms of competition of one department against another, but that's an institutional kind of decision. And if there's a commitment that this health system will improve the health of the people of this region, the people that it serves, or people in the state, then that's across all aspects of the health system, whether it's from bullying to plastic surgery to general pediatrics, whatever. And that means that the way funds are allocated is not based on their market value. So market value for the general specialties is low, psychiatry, the market value for other things is extremely high, but it's only within an integrated health system that we are going to capture all of that, improve the ability of the high-paid earner to do the work that he or she does, but also improve the care that's delivered to those who see the most patients in general pediatrics, general internal medicine areas.
Yeah, no, I love it. From what you just described, from else to become a whole system, very good. Not be a system that pays for don't answer. Else. Here's the asking somebody to pay. It's unsustainable. The real burden shift to me is on health systems for large population because the patients likely in the end are not health systems that keep the population will be managed. And then margin really will be on actual
I do agree with that. I think both things have to happen at the same time. I think that we could have a really fine humming system, and you see this in some places, but it's the patient who still has to do all of this collection of information, calling for appointment, meeting the stone wall every time you turn around.
But if you manage patient population, your system has to
Right, that was my point.
Yeah.
Right.
What did you learn from places like Kaiser doing this?
Kaiser does an extremely good job, but Kaiser is not a safety net. Kaiser gets to pick and choose who they insure. And you don't here at Sparrow Hospital, and we don't at VCU Health System, because we are the emergency department that everybody comes to because they know they can, whether they're documented or undocumented, whether they have insurance or no insurance. So they can achieve a lot of efficiencies in a system where they can be very confident of their revenue streams. We have to tool up for both good revenue streams and bad revenue streams, fluctuations in those that will go according to who's in different offices, elected offices. So we have to have a lot more flexibility than they do. But yes, it can definitely be done. But I would say that that we still run the risk of having systems that work very well unto themselves and are disconnected from the actual improvement in health. And even in population health, there's that risk. So that's the caution that I ask us to think about in the concept of shifting burden. Oh, the HMO question, yeah. Well, so for example, Virginia Premier, which covers 200,000 lives and is about $1 billion revenue operation, their margin is never good, but it's breaks even, which is what we ask of it, because basically they put so much into infrastructure support, their outcomes are amazing. So they have patients who choose to stay with them over long periods of time, which is very unusual for a Medicaid population. They have maternal prematurity outcomes that look like higher SES populations because of the high touch that they use for every member of the organization. By that I mean a community health worker who visits the family. When I first arrived, I asked the CEO of Virginia Premier, how do you achieve this? How do you achieve these kinds of outcomes among families that are so vulnerable and have such complicated disease? And he said, well, as soon as we know one of our members is pregnant, we take diapers to the house. And I looked at him, and I'm thinking, is he making a joke or is he being upset or what? But it was very serious. It wasn't the diapers that made the difference. It was that someone went to the home of this woman and said, here's something you might need. And I'm here and I will help you get to your appointments. Let's talk about your medicines. Do you need food? How are you doing with the other children? Do they need to be connected to somebody? And then that pregnant woman, in loose terms, had a friend, had a guide through her pregnancy. Stayed, they did this for every member who was pregnant among the 200,000 people, most of whom are women and children. And their outcomes are amazing. But their margin's not very high. It doesn't have to be, that's right. The question is, how do we scale this up? And can we do this in an unmanaged population? Because we're never going to be totally managed. The the right to choose is very, very strongly held. And so people are they're going to want to move between systems. We took a huge risk at Virginia Premier and took on an additional like 30,000 covered lives of people who are dually eligible, which is another government term, meaning they get both Medicaid and Medicare, and they only qualify for that because they're extremely complicated. So most of them have 3 or 4 or 5 conditions, and they have choice. So they don't have to stay in our system. But we found now over 3 years that they do stay because of the quality of the interaction that they have with people. It's made them choose us. That's an important lesson. And it's why we keep Virginia Premier. We get calls every week, don't you want to sell it? Why do you want to keep your managed healthcare plan? And University of Michigan sold their Blue Care, remember? Was it Blue Care? No, I'm mixing up. It was Care. And they probably wish they had it back now. Not because it contributes so much to margin, but because it allows you to learn how to do a better job in getting those good outcomes for the patient. Yes, I agree.
Then some of what applied here really is complicated.
Yeah, I agree.
I want to, of what I've seen we were talking to representatives about access to care, the simple getting rides. And they have already in the process whereby students are pregnant.
Yeah. This is what we do at Virginia Premier. We have a whole transportation fleet.
Yeah.
And now we've realized that we have some downtime when it's off clinic hours, and those drivers and those vans are taking patients from the ED to their home. So they're not sitting in the ED waiting for discharge. So there's a lot of these things that we can think about connecting, like Steve just described. Another example that is kind of like a duh type of moment is Virginia Premier realized that they had in their database every opioid prescription that was written on those 200,000 people. And they also knew every person among the 200,000 would be pregnant. And they linked those two for the first time. So that whenever an opioid prescription is written for a pregnant woman, a flag comes up and a special team pops into action, notifies the OB-GYN doc, the family medicine doc, whoever's caring for that patient, and notifies the patient. Do you realize that this med could be harmful to you or your child? So that was just like a matter of using data we already had, but mobilizing some action around it. Yeah.
There are a lot of places that don't have models. Primary care, especially the hospital, and some of those models already exist for them to or offset expenses to be done.
Yes.
That's one point. The other point is you mentioned that supposedly they're for them.
I didn't say they should. I'm saying that some people think they should.
Well, we took it.
Yeah.
Might they're more cost or just dance around before you don't have enough money to retire, and then
That's
they
right.
can't work when they get older.
That's right.
So they're not going to medical care.
That's right. And that's a huge thing for us to think about. A deterioration of the health of the elderly when it unnecessarily, and then episodic use of our ED rather than our clinical mainstream care. That is, I think, that's what nobody wants to talk about when they have these amazing plans for access to care. That means if you can afford it, you can have access. That's not really insurance. Yeah. Yeah. Right. No, I think that in many ways, that is a hugely untapped area. And I mean, this might be kind of far out and may not be what you're thinking about. But when we talk about telemedicine on the phone and the app, there may be a large number of people across all age ranges who would like to work from home for some period of time. Whether I think back to when I had my children and I was on a maternity leave, if I could have had an extended leave and worked from home X number of hours, responding to the calls that come in on the app, I would have jumped at that. If I could look forward to that in my retirement, but I could still have that connection, but do it in a manageable way, so I wasn't, tied down to a place that interfered with my plans. I might jump at that too. And I think there's a huge group of people that we are not tapping into that perhaps our telemedicine applications might help us work with. But the other thing is learning how to bring people in and out of our systems and providing care is very difficult. And it needs to be done because we have untapped talent. But it's a difficult thing for everyone concerned.
Thank you all.
Yes, thank you very much.